Welcome to our web symposium, Carbon Fiber Implants in Treatment of Spinal Bone Tumors. We have with us distinguished guests, Dr. Stefano Boriani and Dr. Hammer. Dr. Stefano Boriani is working at the IRCCS, the Galeazzi Orthopedic Institute in Milan, Italy. One of the leading worldwide experts in spine oncology. Thank you, Stefano, for joining us. And then we have with us also Dr. Stefan Hammer, the head of spine department at the Heidelberg University Medical Center in Heidelberg, Germany. Welcome to you as well, and thank you for joining us. Dr. Boriani is going to talk about carbon fiber in spine oncology, a quest of 20 years. Dr. Boriani, thank you for joining. Please.
Thank you very much, dear. Let's share my screen and start the presentation. Well, thank you for inviting me, and hello to everybody. My name is Stefano Boriani. Now I'm working in Milano at Istituto Orthopedico Galeazzi. You can see here on my back. Really, I'm speaking to you sitting in front of my institution. But I have a very long career working in bone tumors, starting at the end of last century. And so I had more than 30 years to work on bone tumors on the spine, collecting many cases, mostly at Rizzoli Institute, which is a major oncologic institution in Italy, and another hospital where we could collect bone tumors coming all over from Italy. Most of the cases, as you can see here, were primary tumor, and so it's not exactly what happened in the normal activity where most of the tumors are metastases. However, today my topic, my goal, is to deal about this new system for the fixation of bone tumors. Is also in degenerative, but we are especially focusing on the safety and effectiveness of carbon fiber reinforced PEEK composite system in the treatment of bone tumors in the spine. Indeed, why we need of this system, and which is the reason why this is really very helpful for spine oncology. What we need for a system? We need obviously a system which is stable and with a very good fixation, even in osteoporotic and in post-radiation spine. We have a system that could be able to promote bone graft integration. Specifically of spine oncology, the need to follow up the imaging of these patients, so early detection of local recurrence is mandatory, so less artifacts, it is better. And last but not least, today, aggressive reverse surgery is reducing due to the major collaboration with radiotherapists, with the new technique of radiotherapy. So a system which doesn't interfere with radiotherapy is very useful. So let me start a little bit since the beginning with the story of the treatment of bone tumors in the spine, which is a little bit the treatment of spine and bone diseases. We started with stainless steel, then started the era of titanium, and then today we are moving to a new revolution with a new composite carbon fiber PEEK system. And also the technique evolved over the year. Here on the left, you can see a vertebrectomy performed in April '94 with a combination of front and back surgery together with wide opening, with extensive damage on the tissue, with the stainless steel fixation, with the double approach, first posterior and then combination of anterior and posterior. In the middle, you can see a typical surgery of early 2000 by a combination of first anterior approach and then posterior by resecting en bloc with the titanium system, posteriorly located. And then on the right, what we are aiming to combine two different staged approaches with possibly a mini-invasive approach from an anterior approach with a carbon fiber system to get a full fixation with a completely titanium-free system. So why carbon fiber? Which are the main feature of carbon fiber? We know that carbon fiber is something very new, very advanced. If you have flight with the 707, 787, you can realize the advantage of this new aircraft with the bigger windows. And so also on the sea, there are very fast and effective ships. And you know, I'm speaking now from Bologna, which I'm living, and I cannot forget that Lamborghini is fully done in carbon fiber to get the best of the fatigue resistance of this material. But since many years, we were working on carbon fiber, and since the beginning of our experience on tumors, we were using cages in carbon fiber, following the experience by Brantingen. Why cages are important than in carbon fiber? As the modulus of elasticity of carbon fiber is very similar to human bones, much lesser than titanium, and very similar to cortical femur. This means that the sharing of forces is very similar, and so bone graft is promoted as very, very, very quick. And we were very curious about these advantages of carbon fiber, even versus PEEK. So we did some experience in the laboratory, thanks to the University of Ferrara, very close to Bologna. And so we did a study comparing the ability of osteoblasts to grow over carbon fiber and over PEEK. And we could demonstrate that over carbon fiber, the osteoblasts are growing much faster. So there is a very interesting combination and very, very interesting attraction of carbon fiber to osteoblast, which is easy to understand as our body is done mostly of carbon. And so it's easy to understand that osteoblasts prefer carbon fiber than any other kind of material. But as I told you before, now it's very important the combination with the radiation. Both from the point of view of diagnosis, as image artifacts is very reduced, so it's possible to see a local recurrence early, but also radiotherapy is easier and more effective due to the fact that, this system is radiolucent. And with the new system of accelerated particles, there is no or very limited backscattering effect. It means that if we use proton therapy with titanium, there is about 60% of transmission and a lot of backscattering, while the transmission with titanium is more than 90%, close to 97%. So these features are very well known since many years, and carbon fiber systems are using in the treatment of bone tumors of the limb and in traumatology of the limb since many years with a very good result, as you can see here in this humerus pathological fracture treated and submitted to radiation, and an excellent result. And also the experience that was done by our colleague radiotherapists were very useful. And so they studied on phantoms the mean values of useful unit. Here you can see in the 3 regions of interest of titanium versus carbon fiber implant, and you see that the mean Ansfield units is quite less, close to carbon fiber PEEK implant versus titanium, and also the accuracy of the dose calculation is quite better with carbon fiber rather than with the titanium. So it means that the advantages are really very interesting from this point of view. Let me introduce now this system that has been introduced quite recently, only about 7 or 8 years ago. And it was possible really to realize a fixation system in the spine as soon as it was possible to have these locking elements. So the combination rod to screw is allowed by the locking, by the pressure of this small element together with the tulip. And as I told you before, the screw of one element in the other in titanium is not possible. So all the advantages we have already considered can be applied also with this fixation system. The feature of the screw was very interesting. These are polyaxial screw, and they have also a very thin titanium shell. It's less than 50 micron. It means that there are no artifacts and no interference with the proton therapy, but it's possible to visualize even on the normal X-ray, on the standard X-ray, and bone integration, according to some experience, is quite better. So the carbon fiber has this very thin coverage by titanium. So let's see some clinical advantages, some clinical possibility in that this system allow us. Let's consider the problems that the treatment of primary bone tumors in the spine can encounter. For example, this is an osteoblastoma-like osteosarcoma in a young woman, which is the feature to be very huge and going all around the dural sac. It means that there are some lack of feasibility criteria, as there is indeed no space to enter in the canal without any tumor. So in block resection could be possible only with a very high morbidity, with a big loss of function, as we should consider to resect a lot of nerve roots. So at least it's needed an intentional transgression to save some function. But if you want really to do it, in any case, the tumor will break, and achieving a tumor-free margin will be impossible. So an incidental transgression is the minimum that we can expect in this case. So indeed, it's such a complicated way just to say that here in block resection is really not feasible or not practical. So which is a possible solution? The solution is to combine obviously chemotherapy as osteosarcoma, but a gross total double approach, intralesional excision, the best we can do, but by intralesional, with the composite carbon fiber reinforced peak fixation anterior and posterior with the cage anteriorly, and then submit the patient to carbon ion radiotherapy. So we can mix the best possibility to approach to such a difficult case. Here you see another problem that we can encounter, which is a huge chordoma. Many of these chordoma are such like this at the onset, which is growing the canal, which is invading both the psoas area. So also in this case, to achieve a full, completely tumor-free and block resection is extremely difficult. The border from the tumor with the epidural space is very, very thin. So it's almost impossible to resect it without leaving some part of the tumor there. And since the literature review, we know that any surgery, whether anything appropriate or inappropriate, when combined with the radiation therapy, will likely result in a higher local control rate versus surgical resection alone. This is particularly true in cases like this, where at the end of the block resection, you can find a lot of small area of violation of the margin. So we cannot consider, we cannot be sure that even such a huge and block resection, and not huge, such a difficult and block resection will result in a good advantage for the patient. So the best solution today seems to try to do our best in block resection, but to do a reconstruction with a custom-made carbon fiber cage connected with all the posterior system. And then now it's possible to refer this patient for carbon ion treatment with the best result that you can achieve. Another problem is then when we use this very sophisticated titanium system, you see here that we have a 3D printed cage in titanium. When in the case that unfortunately there is a local recurrence and we try to refer this case for radiotherapy, and then the radiotherapists send the patient back saying that they cannot do radiotherapy in cases like that. So they ask us to remove all the titanium system of the posterior system to replace with Carbofix, and also to remove the titanium cage and replace with a carbon fiber cage in order to allow for carbon ion treatment. For the most common surgery, which is metastatic, the golden standard today is the best combination with radiotherapy again. And thanks to the experience from the Sloan Kettering in New York, where stereotactic radiosurgery is used very extensively, and they achieved an excellent result with the treatment of stereotactic radiosurgery with a very low grade of a very low rate of local recurrence. So in this case, between the surgery, which is just to separate, to create an empty space between the tumor and the area to be submitted to radiation, if there is a risk of fracture, the best solution could be to combine with a carbon fiber system, which is radiolucent and which allow the best radiotherapy procedure. So this is an example of breast carcinoma recurrent after radiotherapy performed 1 year before. There is a huge local recurrence with invasion of the canal, is basically 1C, oligometastatic disease. And so we did a separation surgery, carbon fiber fixation, and then stereotactic radiosurgery as a re-irradiation technique. And here you can see the result. The tumor is being completely approached by the radiotherapy and now is ossified, and the radiolucent fixation that you see is still stable after 2 years without any evidence of growing of the disease. This is some numbers of our experience: 65 primary tumor, 39 metastases. Most of these cases are recurrent at every level of the spine. And what is very interesting that many patients are over the age of 60, and even in the patient with osteoporotic spine, we can rely on a good fixation. The construct remains stable even in severely post-radiation osteoporotic spine. And I showed you this case to demonstrate what I'm telling. This is a woman, 76 years old. She had a dedifferentiated chordoma. It means an osteosarcoma which developed over a chordoma, and it's very difficult and rare situation. We could combine the patient with the comorbidity. You see that we had also to perform an endovascular aorta replacement. So she received a gross total excision with carbon fiber implants and was referred to radiotherapies for carbon ion, 73 grays. It's a very aggressive dose of radiotherapy. And after 3 years, there is still no evidence of growing of the disease, no tumor progression, but there's a severe osteoporosis increased maybe by the radiotherapy, but the implant is still stable, which is a very good advantage. So I can conclude telling you that there is this system allow a very good screw bone interface, even at long-term follow-up. The construct remains stable even in difficult cases after radiation therapy. It's very interesting to remind that this system has a module of elasticity, which is very good. So if you put some bone graft, they can be submitted to the same load, and the bone graft will be, integration will be quite better. There is a very low level of artifact, allowing early detection and early treatment of local recurrence. And I think that today this is the best surgical procedure which can be combined with the best radiation therapy. So thank you very much for your attention, and I'm ready and available for any discussion on this topic.
Dr. Hammer will present one of his cases. Dr. Hammer, please.
Well, thank you very much for introducing me, and thank you very much for giving me the possibility to present my case. First of all, I need to mention that we here just started with using that carbon fiber. So the expertise is very obviously with Dr. Boriani, not with me, using a carbon fiber. But what is interesting is maybe I can show you I can show you how easy it is for a first-time user to use the system and to address it. So the case I'm presenting is, is a 22-year-old female patient diagnosed in December in 2019 with a synovial sarcoma. And the synovial sarcoma was attached right to the bone of the lumbar spine. The initial tumor stage is as seen with G3, aggressive, but no metastases and just local. So looking at the picture, looking at the CT scan, it's quite big and it's right attached to the lumbar spine. So especially the facet joint of L2-3 and L3-4 were like interfered with the tumor. And as you see, the size with 77, 60, 154, it was quite big. So the tumor board decision was made, and there was said to have a neoadjuvant chemotherapy and also a boost of radiotherapy. And in the control MRI, we stated in May that there was a mild size regression and still no metastases. So that's what the MRI shows. And especially here, it's right attached to the bone. And if you see here, that's the facet joint, and also going towards the neural foramen, and it's right attached to it. So so the problem was, or the goal was, it needed to be like a total resection of the tumor, which also means that part of the bony spine needs to be also resected. So we did the surgery in June 2020 with tumor resection and also resection of the facet joints L2-3 and L3-4, which left the lumbar spine with a instability in these segments. So we stabilized it with the carbo fix instrumentation. So this is the tumor. That's the midline of the spine right here. That's the tumor we addressed, and closer up. This is like part of the bony spine, and we took here the facet joints away in these both areas to achieve an R0 resection. Then we put in the screws on both sides. We open also the other side from the same approach, and then attached the rods. And this is then the final X-ray that was shown with proper placement of the screws. And you can also, on the left-hand side, see the rods very mildly. It's a mildly shaped, but you can also see the rods on the X-ray. So this result was a stable lumbar spine with only a mild sensitive deficit on the left-hand side where the tumor was at, because we needed to go right to the segmental nerves. And the final pathology report was meant to be an R0 resection. But what's most important, because it's a young patient, is to see what's going to happen next on. So the follow-ups that are needed with MRI and with CT, to have the opportunity to have a clear view and have a clear idea whether the tumor is going to go back or not. So this was not a very difficult case, but it was the first case, and I found it really easy to work with it. And so far it worked really nice. So thank you very much for your attention.
Thank you very much, Dr. Hammer. Dr. Boriani, do you have any comments regarding the interesting case of Dr. Hammer?
Well, I think that it is an excellent choice to combine surgery with the multidisciplinary approach. It was very, very difficult cases, you know, the prognosis in this case is not good. So the only possibility is to combine, as I told, the best multidisciplinary treatment with the best surgery ever done. I think that they did the best that could have been done, and I think that is an excellent utilization of this system.
I'm curious to know, thank you. I'm curious to know what is the workflow when such a patient comes to your department, Dr. Hammer and Dr. Boriani. Do you have a tumor board, or how close are you working with the physicist and with the oncologist regarding determining the right treatment for this specific patient? Dr. Boriani?
Well, yep.
No,
Sorry.
We are some step back, as unfortunately most of these cases are not centralized, and we have not a real tumor board, but this is not good. The best organization for treating bone tumors is to have a tumor board where all the specialty can, all the disciplinary can meet. On the contrary, in most of our cases, which are coming from different parts of Italy, we have just to take our telephone and call the chemotherapists who already started with the chemotherapy to understand at this point they are, if it is possible to do also radiotherapy. So I have to take the phone and call the other one. And so we are in a very unfortunate situation which requires a lot of time and a lot of patience to combine different experts from different parts of Italy. I know that in other hospitals in Milano, they are best organized, as you are in Heidelberg, with a tumor board, but it has been always a dream of, but all over my life, I could not be really able to organize such kind of meeting. But I think that this is a golden standard.
And how is it, Dr. Hammer, at the Heidelberg University Medical Center?
Well, we here in Heidelberg are very, very lucky to have like all the possibilities that are out there. Also, at the University of Heidelberg, we have the National Center of Tumor Diseases. So in case like a patient like this shows up, they're all presented in a tumor board, and they're all the specialists sitting right in there and discussing with each other and finding the best treatment and the best possible procedure for the patient. So we're really lucky to have this right here.
Okay, thank you. We have one question here from the audience. The question is, I performed a 10-level decompression and fusion recently.
I was typing, but
okay. I inserted carbon fiber screws at every level and found it very difficult to connect the rods and the screws together. Short level constructs are easy, but long constructs are very difficult if there is excessive kyphosis or deformity. What tricks do you have to solve this issue?
Well, I was typing the answer. And really, you're right. And 10-level fixation with the carbon fiber system is very, very challenging, very difficult even for very expert surgeons. And so I do not recommend to those who are starting using this system to start with such a difficult surgery. As you know, the limit of the system is it is demanding. So you need to know exactly how to perform it. And you must know that at the moment still the rod cannot be bent, cannot be contoured on the operating field. So it means that the screw must be exactly in the line. Otherwise it will be almost impossible to connect to a pre-bent rod. You have a very large choice of different kind of curvature which are provided by the industry, by Carbofix, and you also can apply for a custom-made rod. And so it's better that planning is done before, and with the consultation with VIR, and they can give you the best possible rod for your situation. But even after that, your screw must be exactly in the right line, not only in the sagittal plane, but also in the coronal plane. And so it's very useful maybe to use a system of navigation or to apply the master of your attention, if you have not navigation like us, to put the screw exactly not only in the right line, but also in the right height. So if it is a little bit too deep, then it's not possible to connect with the rod. So you're right, this is very difficult procedure. And but the advantage later is that you have a system which can be combined with proton therapy and with carbon ion treatment. So for the patient will be a big advantages. For the surgeon is a big difficulty.
Yeah, thank you, Dr. Boriani. Any comments, Dr. Hammer, from your experience?
Well, I just have one experience, but even in two segments, of course, we look at the instrumentation up front, and we knew and we were told that it's very important to be like in one line, and as Dr. Boriani mentioned, also sagittal and coronal plane. So we tried to do that right away, but still, if it's only like a few millimeters out of the line, you're gonna experience it once you try to bring the rod in, adjust it to the tulip. So I can imagine 10 level is quite challenging.
I would like to elaborate what Dr. Boriani mentioned. We have the possibility for customization of rods. Usually these cases are pre-planned, elective cases. So what we need as a company via our distributors or directly to us, you can send us a sagittal CT or an MRI, and we can send you a design for your evaluation. And accordingly, we could produce a custom-made rod in very challenging cases where our regular pre-bend rods do not fit. So this is certainly a possibility. Is there any difficulty with intraoperative visualization?
If I have to answer, I think no, as this very thin titanium coverage is enough to see in the intraoperative radiology, intraoperative amplifier, so no problem. And
So,
there is somebody asking about the fixation of the craniovertebral junction. I think that could be an excellent idea, but should be discussed with Dvir, as at the moment I don't think that there is anything else that a custom-made kind of fixation. But I think that especially for cleaver chordomas could be really a great advantage. So I push Dvir to think some devices to achieve that fixation.
okay. Dr. Hammer, what was your experience with visualization as a new user?
No problem at all. It's really easy, and as already mentioned, this titanium layer is going to make it easy to exactly know where the screw is at.
Okay. Are you using navigation intraoperatively, Dr. Hammer?
In special cases, when we perform like pedicle screws in the cervical spine, then we do use navigation. Or if it's like a very difficult case and has been several surgeries performed before, and maybe the bony stock that you can use for the screw is not good in so many places anymore, then yes. But we have the possibility in the hospital, but we do both. Most of the cases we do not navigate.
Okay, thank you. We have one more question here. Hello, Dr. Boriani and Dr. Hammer. Thank you for your presentation. I'm interested in comparing titanium and carbon fiber in terms of clinical outcome and radiotherapy outcomes. What outcomes do you believe the carbon fiber PIC will be superior in? For example, intraoperative and postoperative complication do you believe that in most cases their clinical outcome will be comparable to titanium or better?
This is for me?
Yeah, Dr. Boriani.
Well, as I tried to explain at the beginning of my presentation, we are in front of a new revolution. So we were very happy with stainless steel, but we moved to titanium with the same stability result, but with some advantage. It was better compliant with the forces. It was better from an image point of view. And now there is another revolution, which is at the moment limited to the treatment of spine tumor, which is to move to a system which is as stable, as effective from a mechanical point of view as titanium, but has the advantage to a good combination with radiotherapy. And this is a very important point for those who know what does it mean performing an en bloc resection in a patient for a tumor, or performing very aggressive spine tumor surgery. For the patient is difficult to lose function, like the movement of a foot, to have a better oncological result. Now we can have less aggressive surgery, as we can rely on very aggressive radiotherapy, but we need carbon fiber fixation. So I think that this is a new revolution. It's something that will change also our attitude in front of spine tumor.
Okay, thank you. What is your view, Dr. Hammer, from the case you have performed so far?
Well, from this case and also from other cases, just using titanium, we always have in the tumor board the discussion with the radiotherapist, and they hate any kind of metal anywhere near where they want to do their procedure. So they are very happy for new cases with carbon fiber, with not having these interference with titanium or other kind of metals. So that's what they've been asking for, especially also in Ewing sarcoma. In young patients, there's also always the question whether you do a post-surgical radiotherapy, depending on how urgent the surgery is, if they have neurological deficits. And then they always have the problem to be precise and also to bring the right dosage right to the place where it's needed. So this could be, this is an excellent opportunity to have this advantage. And I also asked about stability, but you and also Dr. Boriani kept telling me there's no problem with stability. So first time you have this in your hands, you think about it, but you have the experience, and so I have trust, and the future is going to show me and convince me also.
Okay. So, Dr. Boriani, Dr. Hammer, thank you so much for joining us. Thank you so much for all the audience worldwide who are joining us. And we wish you all a peaceful day or night. Thank you so much.
Thank you.
Bye-bye.
Thank you. Bye-bye. Thank you.
Thank you.
Bye.